Hi, today's topic is hypertension, and yeah, this topic will be very long, and it's not possible to cover the entire hypertension topic in one video. But I'm going to cover all the points which will come, all the questions which will come in the theory exam. So yeah, let's start with the hypertension. The first question is, what is hypertension? So according to HA guidelines, now we don't say that hypertension is more than 140 by 90, but now we say that stage 1 of hypertension is more than is 130 to 139 or 80 to 89 millimeter Hg, millimeter mercury. So more than 130 by 80. Okay. And stage 2 is more than or equal to 140 by 90. And elevated BP is now considered as 120 by 80 more than that. Okay. So now it's changed. But we don't tell a person he's hypertensive just by one reading. We'll at least have two reading. For example, if a patient comes to us in OPD and his BP is more than 130 by 90, 130 by 80, we won't say that he is having hypertension. We'll ask him to take rest, and after 30 minutes, we will take his BP. We'll also ask the patient if he had any tea or coffee, or if he had done smoking in the last 30 minutes, that because those factors also increase BP, so we'll ask him to take rest so that his BP can decrease and we can actually check his BP and know the values. So we won't tell that a person is hypertensive just based on just one reading. Okay, now in exam the question have come, what are the causes of hypertension? Now there are two. You can classify it into two things: primary hypertension or secondary. Primary or essential hypertension. When there is no underlying cause present for blood pressure to be elevated, which is almost 95%, this is known as essential hypertension. There is no cause for it. And then there is secondary causes. Now, there are multiple secondary causes, so many, but we are only going to remember the most important one. The most common secondary cause is renal parenchymal disease. Then renal artery stenosis, polycystic kidney disease, pheochromocytoma, thyrotoxicosis, or Liddle syndrome. There are so many, but right now we are just remembering six for the exam. Now let's talk about something. Now here there is no pathogenesis of hypertension, but what we are going to study is how it causes other problems. Like, okay, so there is high blood pressure in artery. So what it will cause? Because of more blood pressure in artery, peripheral resistance will be more. Thus, left ventricular will get more stress to pump blood. So it will cause left ventricular hypertrophy. As we know, in a hypertensive patient, over a period of time, there will be left ventricular hypertrophy, which can be detected on ECG as well as on echo, 2D echo. Okay. High blood pressure in artery will also cause tears in tunica intima, and if in those tears there is fat deposition, then a person can have atherosclerosis, which can lead to coronary artery disease or stroke. Also, there will be weakness of vessel wall, which will cause either aortic aneurysm or aortic dissection. If the artery gets thickened, then there can be retinopathy. As we know, in hypertensive retinopathy, diagnosable change, first observing change will be arteriolar attenuation. So retinopathy and GFR will decrease, which will cause CKD. Okay, now we'll go to clinical feature. Now remember, in clinical feature, there is no symptom of essential hypertension. All the symptoms will be of its secondary causes. So we are not going to talk about any clinical feature here. In the signs, just remember that PP will be elevated and it has to be taken 2 times. Then only we can tell the patient is hypertensive. Okay. Now, investigations. Now, there are some general investigations which we do in every hypertensive patient. Urine chemistry to check if there is loss of albumin, to see if he is having any renal problems. RFT electrolyte to again check for the kidney function, blood glucose, lipid profile to assess for future coronary artery disease, and 12 lead ECG, which might show left ventricular hypertrophy. Now, in exam, there is one question which have come where specialized investigations for hypertension. Now, why specialized? These investigations will tell if the person is having any secondary causes contributing to the hypertension. This is also known as hypertensive investigation protocol. So first, chest X-ray. It can detect coarctation of aorta or cardiomegaly. Ambulatory BP to rule out white coat hypertension. And also in ambulatory BP, we can see that there is no dipping of blood pressure in normal patient at around 4 a.m. to 6 a.m. there will be 10% fall in BP, but in a hypertensive patient it won't be there. Okay, next. Echocardiography will show LVH, left ventricular hypertrophy. Renal USG might show renal parenchymal disease, and renal artery Doppler will show renal artery stenosis. And urinary ketocolamine might show pheochromocytoma. So you can remember investigations as per the secondary causes, or you can remember secondary causes as per the investigation. Okay. Now we will go to the treatment. So okay, whom to give antihypertensive drug? If a person's BP is more than 140 by 90 and he's having low ASCVD risk. Now what is this? Now this is a score which we do to calculate if a person can have future MI or stroke episode. What it includes: age, gender, diabetes, cholesterol level, and BP levels. It is available online. A person can check a person can use it and check how much risk he have in the future. So if a person's BP is more than 130 by 80, but his score is more than 10%, then also we have to give antihypertensive drug. If he is not meeting both the criteria, then we can ask him to do lifestyle modification. Now, what are the lifestyle modifications? First is DASH diet. What in DASH diet, increase fruits and vegetable, low fat dairy products, which mean low tone milk, lean protein, 6 gram or less salt, reduce alcohol and smoking, weight reduction, BMI, like here weight reduction, we'll ask him to reduce his BMI by less than 25 kg per meter square. Okay. Increase physical activity and yoga. Here physical activity one can suggest 30 minutes of 30 minutes of walking for 5 days a week. Okay. Now we'll go to the pharmacological treatment. Now you have to remember it like this. If someone's age is less than 55 years, then we will prescribe him ACE inhibitor or ARBs. Now ACE inhibitor is considered as best drug because of its ability of vascular remodeling. That's the first point. Or ARBs, telmisartan. In India, we call it Telvas 40. And if the age is more than 55, then we will give him CCB, calcium channel blockers, such as amlodipine. In India, we call it Amlong 5 mg or something. Now, if the now every 2 weeks we will check his BP, and if the target BP, which is less than 130 by 80, is not achieved, then we will increase the dose of drug. And to its therapeutic dose, maximum therapeutic dose will increase. If then also it's not reaching the target, then we will start combination. First combination is ACE inhibitor or ARBs plus calcium channel blocker. Same thing, and if again target BP is not reached after 2 weeks, then we will add diuretics such as hydrochlorothiazide. And if still target BP level is not reached, then we will uh, call the person as resistant hypertension. And then we can add beta blocker prazosin. But before adding this, we have to do proper examination that why his BP is not reducing. Okay. Now some extra point. Beta blocker can be added, but when patient is known case of congestive heart failure or chronic stable angina. If patient BP is not reaching target BP, then the most common cause is non-compliance to treatment. We have to see if the patient is really taking its drug or not. One way to identify this is we can check his tablet box, how many tablets he have taken. For example, if we have given him 30 tablets and he have taken only 15 tablets for in an entire month, that means he is non-compliant. Okay. Now some other points. What are the risk factors which causes hypertension? But this question have also come in exam. So genetic, family history, more in males, more in people who take high salt diet, high salt intake, alcohol, and smoking. What are the complications? I've already discussed in pathogenesis, but again, stroke, aortic aneurysm and dissection, CKD, coronary artery disease, retinopathy, left ventricular hypertrophy, atherosclerosis. Okay, now some random points. What is white coat hypertension? When BP is more at clinic but low at home. What we will do? We will do ambulatory BP monitoring. When BP is more at home but less at clinic, then we will definitely start the treatment. Hypertension emergency or crisis. When BP is more than 180 by 20 with end organ damage. This is compulsory. And when hypertension emergency, BP is higher than 180 by 120, but there is no end organ damage. Now, what is this end organ damage? Acute heart failure, MI, aortic dissection, acute kidney injury, retinopathy, or I have seen a patient in which because of such sudden increase in BP, uh, there was a short episode of blindness. But when the BP resolved, BP decreased, his blindness, his eyesight again came back. Stroke, transient ischemic attack, and encephalopathy. That's all for the video of hypertension. Hope you like the video. Please subscribe and like the video. Thank you.